Contact tracing, cluster identification are the terms we have heard a lot in 2020, and surveillance formed a critical component of cluster identification. I am Srinivasa Janagama, presenting this abstract on surveillance on behalf of my co-authors at Stanford University School of Medicine and GVK Emergency Management Research Institute. And we do not have any financial conflict of interest to disclose. Our primary objective of this study is to check the utility of call center ambulance dispatch data for COVID-19 cluster surveillance. We did a retrospective analysis of call center ambulance dispatch data and COVID-19 case count from the state of Telangana, India. The dispatch data is from a state-sponsored pre-hospital ambulance dispatch system catering to over 35 million people of Telangana. And the COVID data is from a crowdsourced and aggregated database available online. A group of volunteers aggregated data from various government sources and their Twitter feeds, verified the data and pulled it together and made it available online. For this study, we defined an influenza-like illness call as one where fever and or difficult breathing were reasons for ambulance dispatch. So we included ILI calls received between January 1st and April 30th in the years 2018, 2019, and 2020 from the state of Telangana, India. Our primary outcome measure is a correlation between ILI calls and the COVID-19 cases in the March-April 2020. We selected March and April because Telangana had its first case in the month of March. And there were no cases in February. There were about 10,000 cases in the study period during each of the years, 2018, 19, and 20. But 2020 showed a 54% increase in calls compared to 2018 and a 70% increase in calls compared to 2019. When we lay this data on a timeline, we see the ILI calls constituted about 10% of the total calls received each day by the call center. And in each of the years, there were the 2018 calls, 19 calls, and 20 calls seem to correlate, and there is a statistically significant correlation among them. But when we compare this with the March and April calls, see on March 19th in 2020, we see a spike in ILI calls. This spike continued and the calls tripled in number by April 7th, that is within 3 weeks. The per day calls tripled. Regarding the COVID-19 cases, there were about 1,100 COVID cases reported in the months of March and April 2020 in Telangana. The first case was on March 2nd, and an initial rise in cases was observed on March 12th. This initial rise is followed by a spike in ILI calls received after 7 days. And this spike in ILI calls is followed by a spike in COVID cases about 10 days later. An initial rise in COVID cases resulted in a rise in ILI calls 7 days later, and a rise in ILI calls resulted in a spike in COVID cases 10 days later. This is visually interesting, but we try to find, are they correlated? Is it a statistically significant correlation? To check it, we applied a cross-correlation function with COVID-19 as a predictor and ILI calls as a response. Checked for a correlation of the calls received today with the COVID cases reported today, the day before, the day before, the day before, or the day after, the day after, and the day after. So we were literally sliding the COVID-19 cases on ILI calls. In this chart, each lag is 7 days, and these bars represent the correlation, and bars that cross this blue line are significant. This bar represents the correlation between the COVID-19 cases reported a week back and the calls received today. The COVID-19 cases reported a week back are significantly related to the calls received today. And this particular bar represents a correlation between the COVID-19 cases reported 2 weeks later are significantly related to the calls received today. So, in effect, our conclusion is an above average COVID-19 positive cases are likely to result in above average ILI calls up to a week later. And at the same time, above average ILI calls are likely to result in above average COVID-19 cases up to 14 days later. There is a significant time series correlation between ILI calls and COVID-19 cases, and we definitely conclude that the pre-hospital call center ambulance dispatch data can be part of early warning systems, which aid in outbreak cluster surveillance, identification, and containment. And this has to act in tandem with the community-based surveillance.
Hi everyone, my name is Benjamin Gallo Marin. I'm a rising third-year medical student from Nicaragua at the Warren Alper Medical School of Brown University, and I'm really happy to present our research to you today. Our research is titled Increased Temperatures are Associated with Increased Emergency Medical Services Utilizations in Rhode Island. I do not have any relevant relationships to disclose. Rhode Island temperatures are trending upwards. For the past decades, we've seen higher temperatures in the state of Rhode Island, and scientists have predicted that heat wave days are going to increase all the way to 2050 and beyond. We know that rising temperatures in general are a public health concern, and they have been linked to acute exacerbations, to chronic diseases, as well as increased emergency medical services utilization. Understanding regional EMS utilization changes with rising temperatures ultimately allows us for strategic preparedness. So here we provide the preliminary findings of the first analysis of the relationship between temperature and EMS utilization in Rhode Island. So for our methods, we worked with the Rhode Island Department of Health EMS database, and we linked it to temperature data from the National Oceanic and Atmospheric Administration. In particular, we recorded minimum, maximum, and average temperatures. And we looked at EMS runs and temperatures between June 1st and August 31st of 2018, 2019, or the summers of 2018 and 2019. We then proceeded with descriptive statistics to evaluate patient demographics, chi-squared or t-test analyses, compared patient demographics for those using EMS on days with a maximum temperature over 90 degrees Fahrenheit versus under 90 degrees Fahrenheit. And we used Poisson regression models to calculate the incident rate ratio of average EMS runs for days with a given minimum, maximum, and average temperature. So now onto the exciting part, our results. First, we were able to get a total of 49,538 EMS patient encounters, most of which were actually lower acuity, but there were several classified as emergent and critical encounters. And for our temperature data, we saw that the mean maximum temperature was 82.5 with a range of 56 to 96 degrees Fahrenheit, but the mean average temperature was 72.8 degrees Fahrenheit during this time period. And here what we can see is that the number of daily EMS runs by maximal daily temperature exhibits a positive correlation. We can see that as temperature increases, the number of daily EMS runs in the state of Rhode Island is also increases. Also in our research, we found that patients using EMS on days with a maximum temperature over 90 degrees Fahrenheit were slightly younger as compared to patients in days under 90 degrees Fahrenheit. This was the only statistical difference between these two groups that we were able to find. And a Poisson regression also showed that a positive association between increased minimum temperature, maximum temperature, and average temperature, as well as EMS utilization, was found. So in summary, we found a positive correlation between temperature and EMS runs in Rhode Island. And we believe that understanding the relationship between temperature and EMS use is paramount to guide EMS staffing, emergency alert system, and mitigation strategies. So what are our next steps? We are working to characterize the effects of heat waves on overall EMS utilization across Rhode Island, and also characterize the effect of heat waves on EMS utilization in heat islands versus non-heat island locations across Rhode Island. And hopefully with the findings that we gather from these analyses, we will be able to provide the Rhode Island Department of Health and EMS leadership with several recommendations so that they can enhance their preparedness in the face of rising global temperatures. Thank you everyone for your time, and I'm happy to answer any questions via email. And thank you again for coming to our presentation.
Hi, thank you for viewing our presentation, Prehospital Management of Traumatic Cardiac Arrest in the United States. I'm Greg Peters, an emergency medicine resident at the Harvard-affiliated Emergency Medicine Residency at Massachusetts General Hospital and Brigham and Women's Hospital, presenting on behalf of Alex Ortobati, a general surgery resident at the Brigham, Rebecca Cash, an assistant professor of emergency medicine at MGH, and Ash Panchal, a professor of emergency medicine at The Ohio State University Wexner Medical Center. The motivation behind this study comes from the fact that 2% of traumatic cardiac arrest patients survive to discharge, which is roughly 1/5 the rate of all out-of-hospital cardiac arrest patients. Despite the establishment of ATLS and ACLS for trauma and cardiac arrest respectively, proper management of traumatic cardiac arrest has been difficult to define. Therefore, we aim to describe patterns in pre-hospital management of a nationwide sample of traumatic cardiac arrest incidents, compare trends in blunt versus penetrating trauma, and examine the factors associated with return of spontaneous circulation, or ROSC. We performed a retrospective analysis using the NEMSIS 2018 dataset, a large repository of pre-hospital patient care report data submitted by EMS agencies throughout the U.S. We examined all out-of-hospital cardiac arrest incidents associated with trauma in which the criteria listed on this slide were satisfied. Our primary outcome measure was ROSC, and we included Utstein criteria that were available in the dataset. From an initial dataset of roughly 22.5 million EMS activations in 2018, a final sample of 7,620 incidents met study criteria and had a clear distinction between blunt versus penetrating trauma. Blunt traumatic arrests were roughly 4 times more prevalent than penetrating traumatic arrests in this sample. First, we examined demographic data. Nearly 80% of traumatic arrests were due to blunt trauma. Median age was roughly 51 years, although penetrating traumatic arrest patients were significantly younger. The vast majority of patients were male. Private versus public location significantly differed by type of injury. The vast majority of incidents occurred in urban locations, including nearly 90% for penetrating trauma. Second, we studied pre-hospital response characteristics. All phases of pre-hospital time were shorter for penetrating traumatic arrest, including roughly 7 minutes shorter on average for overall pre-hospital time. This difference is largely driven by a significant difference in scene time associated with significantly fewer procedures performed for penetrating traumatic arrest. Our analysis also revealed that unnecessary procedures might have contributed to prolonged scene time. For example, more than 10% of penetrating traumatic arrests received spine immobilization procedures, despite strong evidence against this practice. In addition, blunt traumatic arrests were marked by higher rates of CPR performed prior to EMS arrival and shockable initial rhythm. Penetrating traumatic arrests were more likely to be witnessed by EMS. Importantly, only 3% of penetrating arrests had a shockable initial rhythm. We then examined patterns in cardiac arrest management. Blunt traumatic arrests were more likely to be defibrillated, associated with the fact that they were more often marked by a shockable initial rhythm. Blunt traumatic arrests were more likely to receive epinephrine, and penetrating arrests were more likely to undergo endotracheal intubation. Of note, roughly 10% of penetrating arrests did not receive CPR at any point, and roughly 60% of all traumatic arrests had no attempt at advanced airway management despite all being treated by ALS providers. Finally, we evaluated odds of ROSC in our sample. In our sample, 26% of patients achieved ROSC, including 29% in blunt and 12% in penetrating traumatic arrest. We then calculated crude odds ratios and performed a multivariable logistic regression to examine odds of ROSC with respect to key variables. A Hosmer-Leemshow goodness of fit test supported our model. This table summarizes our findings, with crude odds ratios on the left and adjusted on the right. In particular, Crude analysis showed that there was a 67% decrease in the odds of ROSC for penetrating compared to blunt arrests. In other words, blunt arrests had a threefold greater odds of ROSC compared to penetrating arrests, or 2.3 times greater after adjusting for other factors. Other factors associated with increased odds of ROSC are highlighted here with the red circles. In summary, we found wide variation in management patterns and significant differences in treatment of blunt versus penetrating traumatic arrest. Only roughly 1/4 of traumatic arrest patients in our sample achieved ROSC at any point, and outcomes were particularly poor in penetrating traumatic arrest. These findings highlight the need for a standardized prehospital approach to blunt and penetrating traumatic arrest. Work is currently in progress to determine procedures associated with ROSC, and future work is needed to generate an improved base of evidence to develop more effective protocols for blunt and penetrating traumatic arrest. Finally, these are a few key references used to prepare this talk. Thank you for listening.
Hi, everyone. My name is Ryan DeVivo, and I'm a third-year resident at the LA County Harbor UCLA Medical Center Emergency Medicine Residency Program. In collaboration with the Los Angeles County EMS Agency, I'm excited to share the details of our abstract entitled The Allocation of Remdesivir for the COVID-19 Pandemic in Los Angeles County with you all. We have no conflicts of interest to disclose relative to this presentation. On May 1st, 2020, the FDA issued an EUA for Remdesivir, an RNA synthesis inhibiting antiviral drug produced by Gilead Sciences. At a time when few other therapies were available for the treatment of COVID-19, preliminary results from the adaptive COVID-19 treatment trial in a phase 3 open label trial sponsored by Gilead, the FDA concluded that the known benefits outweigh the known potential risks. Promising data demonstrated a reduction in length of illness in hospitalized patients. The EUA authorized the use of remdesivir in hospitalized patients with COVID-19 requiring supplemental oxygen or with an oxygen saturation less than 94% on room air, and it was later expanded to encompass all hospitalized patients. In addition, the EUA specified the supply chain for distribution was to be controlled by the United States government to distribute the 949,000 vials of remdesivir made available by Gilead Sciences to hospitals in collaboration with state and local governments. Our study focused on the distribution of the donated remdesivir in the early phase of the COVID-19 pandemic. The purpose was to describe the process by which the LA County EMS Agency allocated and distributed this scarce resource to local hospitals and to describe the patients treated with the donated remdesivir during this period of time. The LA County EMS Agency was tasked with allocation of the donated remdesivir throughout all of LA County, a region spanning 4,000 square miles with a population close to 10 million people. And the number of vials totaling 32,429 doses across 95 local hospitals. The EMS agency initiated a daily poll of all LA County hospitals beginning March 26, 2020 to track admission of confirmed and suspected COVID-19 cases. This data included the daily inpatient census of COVID-19 patients and their level of care. In an effort to maximize benefit and reduce disparities, the allocation of remdesivir was based on the inpatient COVID-19 census for each hospital relative to the total number of patients with COVID-19 in LA County, referred to as the COVID-19 burden. For each allocation, California would inform LA County of the number of remdesivir vials the county would receive. The LA County EMS agency then allocated these vials, assuming a 5-day treatment course to the hospitals based on their COVID-19 burden. The 5-day treatment course was selected as the basis for allocation, given data showing equivalence between the 5 and 10-day course. A total of 7 allocations of remdesivir were delivered to hospitals over a period of 8 weeks from late May until mid-July 2020. And data was collected on patients treated with the donated remdesivir at receiving hospitals from May through December 2020. Treating physicians at the receiving facilities utilize remdesivir at their own discretion based on the EUA guidelines. An Excel template with data dictionary and pre-specified pick lists was distributed with the first allotment of the drug specifying the variables required for submission. For this study, frequencies and proportions were used to assess the categorical variables shown in the graph above. We assessed continuous variables with medians and interquartile ranges, including age, total days on the ventilator, and total days in the ICU, which was broken down into whether the patient was in the ICU upon initiation of the drug or transferred there thereafter. Overall, 5,376 patients were treated with the donated remdesivir at 79 different hospitals between May through December 2020. As of December 15th, 7 hospitals still had some remaining donated remdesivir, totaling 760 vials, but the majority of facilities had depleted their supply by the end of September 2020, if not sooner. For our results, 62% of patients were male, and the median age was 60 years old. 74% of the patients had previously diagnosed comorbid conditions, and you can see our racial and ethnic distribution here. The majority of patients were admitted to a telemetry or med-surg bed at the time of initiation of remdesivir. 41% of patients required ICU care at some point during their hospitalization, and 26% of patients were already in the ICU at time of initiation of the drug. The median length of ICU stay for patients who initiated remdesivir in the ICU was 10 days. For patients who were transferred to the ICU after initiation, the median length of ICU stay was 8 days. Almost half of patients were on supplemental oxygen only at the initiation of remdesivir. 1/3 were maintained on high flow nasal cannula. 9% of patients were already being mechanically ventilated. At initiation of the medication, another 17% of patients subsequently required ventilatory support. The median number of days a ventilated patient required ventilatory support was 11 days. For all ICU care, regardless of timing, the median stay in the ICU was 10 days. The median number of hospitalization days for all patients, regardless of level of care, was 10 days as well. The majority of patients who were discharged returned home or to their prior residence. And overall, LA County EMS's strategic plan to distribute donated remdesivir to hospitals based on the number of inpatients with COVID-19 resulted in the treatment of 5,376 patients, of whom 74% survived a hospital discharge. We described one EMS system's distribution of donated remdesivir. The data was collected at local hospitals, and given the variable length of treatment course, we are unable to confirm that all patients that were treated are accounted for. Hospitals were also allowed to transfer the medication between facilities, which was common between sister hospitals. In October of 2020, hospitals could also purchase the medication directly from vendors. We requested that hospitals not include patients treated with purchased remdesivir in their data submission, but given the overlapping time periods, it was impossible to confirm that some patients were not included. We did not attempt to verify that all patients who received remdesivir met criteria for the treatment. And finally, some hospitals did still have some donated remdesivir at the end of the data collection period in December of 2020, and those patients are not included in this analysis. Overall, we would like to acknowledge the LA County EMS agency staff that coordinated the allocation distribution of the donated remdesivir, and I'd like to thank you all for listening to this presentation today. Thank you.
Hello, my name is Carolyn Burkowski, and I am from the Department of Emergency Medicine at the Yale School of Medicine. Our work is funded by a CDC R01 grant entitled A Multitiered Approach Following Naloxone Resuscitation from Opioid Overdose, or SafetyNet for short. SafetyNet is a community-centered intervention program, and it's designed to enhance participants' abilities to recover from opioid use disorder. We work with participants one-on-one to connect them to the treatment of opioid use disorder, and also a range of recovery services in the greater New Haven area. Importantly, this includes medication-assisted treatment. For those with moderate to severe opioid use disorder who have been resuscitated by naloxone, we wish to increase their access to medication-assisted therapies, for example, treatment with buprenorphine, detox and intensive outpatient facilities, psychosocial resources, and community-based centers. We also wish to decrease the percentage of overdose events, opioid usage, and fatalities at least over 180 days, if not indefinitely. To carry out our work, our intervention involves a unique team comprised of a health educator paramedic. These individuals typically have many years of experience in emergency medical services and paramedicine, and a recovery coach, many of whom have been in recovery themselves. Once someone with moderate to severe opioid use disorder experiences an overdose event and is resuscitated with naloxone, they may become eligible for study participation. The overdose event could have happened in or around the hospital or in the community. And once the person is determined to be eligible, the team will approach the person and may obtain consent either in the emergency department or within 7 days. Once consent is obtained, individuals may be offered an option of 3 tracks. One would be medication-assisted therapy, such as buprenorphine and naloxone. Another is psychosocial support only. Another is educational support only. And interestingly, our intervention allows the individuals to switch among any of these options at any time, whenever they would like. Of course, they're free to withdraw. And we follow up with 2 additional meetings at 30 and 180 days, although we're always following participants throughout that time. We started recruiting in July of last year. We were interrupted by the COVID-19 pandemic. 1,842 encounters were screened. Of those, only 1,528 were not repeat encounters. 393 were referred to the Connecticut Community for Addiction Recovery. 180 met criteria for moderate to severe opioid use disorder and being resuscitated by naloxone. 72 met all the study criteria, 48 expressly declined or were lost to follow-up, and at the time 25 enrolled, 25 expressed interest in treatment and remission, 10 engaged in treatment and remission, 1 has had a documented overdose, 1 has been withdrawn for suicidal ideation, and 8 have been lost to follow-up. I should note that just as of last week, we've had an additional enrollment. Our top accomplishments to date are that we've screened greater than 1,900 cases. We've formally enrolled 26 individuals. We've referred over 400 cases to CCAR. We have expanded referral services for prospective recruits. This is through the American Medical Response Team, and that is headed by Dr. Cohn. We also have forged agreements with community groups to expand potential for recruitment in pre-hospital settings, and those groups include the community health care van. We've also made various presentations at community centers such as CCAR, and we're also going to talk with some of our fellow awardees at an upcoming CDC meeting. Top challenges to date have been enrollment, in addition to securing follow-up pre- and post-study enrollment, and of course COVID-19 almost cost us an entire year of recruiting time. So our current trajectory includes increasing the rate of enrollment. We would like to do this by continuing to accept referrals from the EDs and from CCAR, in addition to the community healthcare van, which is now up and running in the community, and it hadn't been before due to COVID-19. We also wish to work with AMR to facilitate real-time knowledge of transports that are going to one of the Yale EDs. We'd also like to continue to maintain a robust linkage of care in the ED with care in the community. We'll do this by sustaining and expanding our partnerships, and also motivating interest in treatment and facilitating access to it. And we'd like to assist with other community-based recovery strategies. I'd like to thank all members of our research team. They are Joanne McGovern, Rebecca Allen, Dimitri Bakes, Carmen Bravo, Jessica Jolson, Jennifer Provost, Mike Pantalone, and David Cohn. Thank you.
Hello, my name is Yvette Matola, and I'm an emergency medicine physician at the University of Miami Gordon Center for Simulation and Innovation in Medical Education. It's great to be with you at SAEM 2021, even if it's virtual and from afar. Today, I'll be speaking with you about our study on the effectiveness of a simulation-based course in acute coronary syndromes and ECG interpretation for paramedics. None of the authors have any financial disclosures related to the study, the topic, or the course. Accurate 12-lead interpretation is critical to the rapid identification of ST segment elevation MI and acute coronary syndromes by pre-hospital providers. Additionally, paramedics must be able to quickly identify the signs of ACS in order to provide optimal care and activate the cardiac cath lab if indicated. Previous studies have shown that pre-notification of STEMI by EMS reduces door to balloon times and improves patient outcomes. Therefore, it's critical that we have effective training for EMS personnel and ACS recognition and management. The goal of our study was to determine the impact of a simulation-based course on ECG interpretation and ACS identification and management in practicing paramedics. In the chain of stroke survival, we focused on EMS. In collaboration with other subject matter experts in emergency medicine, EMS, cardiology, and simulation education, we developed a simulation-based 8-hour course in ACS and ECG interpretation for EMS personnel. The course included didactic sessions on cardiac anatomy and physiology, history and physical examination, principles of ECG interpretation, ACS mimics, and management of ACS. Hands-on practice sessions included ECG acquisition, ECG and arrhythmia interpretation workshops, and small group simulation scenarios. The course culminated with a review game that was in Jeopardy style to review everything that had been learned over the day. The next few slides have sample content to share with you so that you can see what some of the curriculum look like. This one shows the pathophysiology of thrombus formation after an erosion or plaque rupture. We review cardiac vascular anatomy and the common clinical correlations and complications seen with occlusion of each vessel. This one demonstrates the right coronary artery clinical correlations. The graphics are designed to be visual reminders and woven throughout the curriculum. We use a block model of the ECG to illustrate the leads that are affected with each STEMI syndrome and the vascular correlation. They see this throughout the day, and again, it reminds them when they're looking at the ECG, what goes together and what vascular anatomy is likely involved. This is an example from our case-based arrhythmia workshop where we presented a case, several cases, a rhythm strip, and then review the rhythm after they have answered an audience response system question on what the rhythm is. We also show them an animation illustrated here that shows what is occurring in the heart's electrical system with each dysrhythmia. Management is also reviewed. Both tachy and Brady dysrhythmias are reviewed, and this module was added at the request of EMS agencies that identified that their paramedics needed additional practice with dysrhythmias in addition to ECG interpretation. The animations we have found really help the paramedics understand what's going on in the heart's electrical activity. We also do a 15-case ECG workshop where the learners are given 15 ECGs and asked to interpret each one in a systematic way, filling in their findings. We then provide options via an audience response system of what the interpretation is, and the case with specific ECG findings is subsequently discussed with the whole group, and we pay special attention to any incorrect answers in the audience response system. The research study that we conducted was a pre-post intervention study where each paramedic participant served as their own control. Outcome measure was the change from pre to post course assessment. The assessments were learning objective and content match and included 25 items, including clinical cases, ECG and rhythm interpretation, pathophysiology of ACS, and management. Paired samples t-test using SPS version 26 was used for data analysis. 1,199 learners for who had completed the course and for whom we had both pre-course and post-course assessment scores were included in the study. They represented 35 EMS and fire rescue agencies throughout the state of Florida. The change from pre to post-course was 64.72% to an 89.50%, representing a delta of 24.79%, which was statistically significant. So in conclusion, training that incorporated didactic sessions and hands-on simulation scenarios significantly increased knowledge of ACS identification and treatment amongst paramedics. Marked improvement was seen in 12-lead ECG interpretation proficiency, which allows for more accurate identification of STEMIs and pre-hospital notification. This may lead to decreased D2B times and improved patient outcomes. Additional research is needed to evaluate clinical outcomes after participation in the course. We would like to thank our Gordon Center staff and paramedic nursing and physician instructors, the EMS providers and agencies throughout Florida who participated in this study, and specifically City of Miami Fire Rescue, who had all of their paramedics participate in the course. Thank you for your time. We will be able to answer some questions, but if you have others, you are welcome to contact me. And we want to thank all of you as healthcare providers in this crazy past year.
My name is Darshana Krishnaprasad. Thank you for having me at the virtual SAEM conference. I'm a pediatric emergency medicine fellow at Beaumont Hospital in Michigan. The title of my study is Pediatric Constipation in the Emergency Department, Provider Practice Pattern and Trend. I have no financial disclosures. Constipation is a common chief complaint for children coming into the pediatric emergency department. Prevalence of ED visits for constipation in North America ranges from about 1 to 30%. Constipation is defined as a clinical diagnosis. Guidelines suggest that abdominal x-rays in patients suspected of being constipated is unnecessary and may be misleading. 73% of providers ordered abdominal x-rays for evaluation of constipation. Little is known about imaging and treatment of constipation by provider types. The aim of this study is to describe practice trends by provider type and hospital type. 3 hospitals within a specific healthcare network in the suburbs of Detroit were analyzed. Site 1 is an academic site with both PEM and EM faculty. Site 2 and 3 are community-based with EM faculty. All 3 sites have residents and APPs. APPs include physician assistants and nurse practitioners who provide care in the ED. This is a retrospective EMR review of ED visits of children with constipation. Discharge diagnosis of constipation based on ICD-10 codes were looked at. Children between 6 months to 17 years were included. The timeframe of the study was between September 2017 to March 2020. Exclusion criteria were hypotension, defined as less than 5th percentile for age at any time during the visit, serum pregnancy test positive, and patients who left the ED without being evaluated by a physician. Specific points of interest include imaging, treatment modalities, and disposition, which includes the length of stay in the ED. Now, moving on to results. A total of 4,813 pediatric patients fit the inclusion criteria. 185 were excluded and 4,627 were analyzed. 2 reduced COVID-19 as a confounder. Additionally, 103 patients were excluded. Total of 4,524 were finally looked at. 43 of these were seen by PEM and residents, 3% were seen by PEM and APPs, 18% were seen by EM and residents, 36 were seen by EM and APPs. Our study's population included 48% male and 52% female. Mean age of the population was 9 years. Site 1 had the maximum number of visits, which were 2,312. Site 2 had about 1,558, and Site 3 included 654 visits during these 3 years. Imaging in the ED was very common for the management of pediatric constipation. 3,443 abdominal radiographs were done. Abdominal x-rays were more commonly ordered by EM and APP providers for about 82%, followed by 74% by PEM and APP providers. A total of 758 abdominal ultrasounds were ordered by all provider types. This is shown by the red bar graph. A total of 170 abdominal CTs were ordered by all provider types. This is seen in the green bar graph. This shows the imaging trends of abdominal x-rays in pediatric constipation. The abdominal x-ray ordering trends reduced amongst the EM physicians and increased amongst the PEM physicians during this study period. The most common treatment administered in the emergency department for constipation was laxatives, 1,496 times. The PEM physicians gave the laxatives the most, of which PEM and APP combination gave about 49%. EM physicians chose to give more enemas. The combination of EM and APP gave the most enemas at 37%. Suppositories were given to children less than 2 years of age. The median length of stay in hours is seen here. Site 1, the academic site, had the longest stay, about 3.78 hours. These were our conclusions. Abdominal radiographs were frequently done in the diagnosis of constipation, regardless of the provider type. Enemas were more commonly ordered by EM physicians. Laxatives were ordered by PEM physicians. There were no treatment trends in regards to resident and APPs. Length of stay was longest in the academic center. These are my references. Thank you for your attention, and I would be happy to answer questions in my live session.
Hello, and thank you for coming to this presentation. My name is Alexis, and I'm a fourth-year medical student who worked on this project with Dr. Barrett, Dr. Moskovitz, and Dr. Friedman. I will be presenting History and Physical Exam predict hemoglobin less than 7 grams per deciliter in non-pregnant patients with vaginal bleeding. We have no financial conflicts of interest to disclose. For some background, vaginal bleeding in non-pregnant patients is a very common presentation, with over 500,000 emergency department visits in 2017. Treatment is guided by clinicians identifying a clinically relevant anemia, which we defined as hemoglobin less than 7 grams per deciliter, as this value is a commonly accepted transfusion threshold. Some studies argue CBCs are not helpful if severe anemia like this is not suspected. Other studies have shown that patients and medical professionals alike find it difficult to quantify blood loss based solely on descriptions of that blood loss, i.e. with or without clots, or on the color, or on the number of absorptive pads used. Instead of focusing on descriptions of blood loss, clinicians could rely on symptoms or objective signs of anemia. The symptoms include dyspnea on exertion, fatigue, weakness impacting daily activities, chest pain, palpitations, lightheadedness, or syncope. Objective signs include tachycardia, hypotension, tachypnea, conjunctival pallor, or other pallor. The objective of our study was to determine whether these symptoms, vital signs, and/or features of the physical exam could exclude a clinically significant anemia requiring transfusion. Exclusion of clinically significant anemia in this way may decrease the length of stay in the emergency department and decrease overall cost if a CBC is not indicated. We conducted a retrospective cohort study of 1,122 non-pregnant females presenting with vaginal bleeding between January 1, 2015 and January 1, 2018. Age, race, and ethnicity were automatically extracted from the electronic medical records, while historical data, physical exam data, and laboratory data were manually abstracted by 2 independent reviewers. These were then verified with inter-rater reliability calculations. For our statistical methods, we calculated sensitivity, specificity, and likelihood ratios, and we estimated positive and negative predictive values for 8 features of the history and physical. We also compared vital signs between those with hemoglobin less than 7 and those with hemoglobin greater than or equal to 7. This represents our study sample. The mean age was 35.4 years old, and the socio-demographic characteristics of our study sample reflected that of the Bronx population. 43% identified as Spanish, Hispanic, or Latino, 36% identified as Black or African American, 6% identified as white, and 2% identified as Asian. This table shows the sensitivity, specificity, estimated positive predictive value, estimated negative predictive value, positive likelihood ratio, and negative likelihood ratio for elements of the history and physical exam. The elements we analyzed were shortness of breath or dyspnea on exertion, chest pain, fatigue or weakness, syncope, dizziness or lightheadedness or pre-syncope, palpitations, conjunctival pallor, other pallor, and history of transfusion. We grouped some of the similar symptoms because patient descriptions of these symptoms can and often do overlap. The negative predictive values for the historical elements were uniformly greater than 0.90. The highest positive likelihood ratios for anemia from the history were seen with shortness of breath or dyspnea on exertion with a positive likelihood ratio of 6.69 and a prior history of transfusion with a positive likelihood ratio of 4.88. On physical exam, conjunctival pallor and other pallor were notably predictive of hemoglobin less than 7, with conjunctival pallor having a positive likelihood ratio of 18.36 and other pallor having a positive likelihood ratio of 5.81. This table presents these same statistical measures, assuming characteristics that were not charted in the electronic medical record were a negative finding. Assuming this, if syncope, palpitations, conjunctival pallor, and other pallor are present, there is a high probability that the patient is anemic with hemoglobin less than 7, as syncope has a positive likelihood ratio of 8.34, palpitations of 5.53, conjunctival pallor of 23.10, and other pallor with a positive likelihood ratio of 13.82. Of note, there were 8 patients with hemoglobin less than 7 who reported no non-gynecological symptoms, and 4 had no symptoms or exam findings of anemia or history of transfusion. We also found that vital signs were not statistically different between those with hemoglobin greater than or equal to 7 and hemoglobin less than 7. To conclude, although elements of the history and physical can help rule out a significant anemia, a small number of patients with hemoglobin less than 7 did not have positive findings recorded in their history and physical, making it difficult to use only history and physical elements to entirely exclude a clinically significant anemia. The limitations of this study include missing data in the electronic medical record and the fact that this was a retrospective study. Future research could include prospective studies. Here are the references that we used. And I'd like to give a special thank you to Dr. Barrett, the emergency medicine resident who initiated this project and ensured my learning as it progressed, and to Dr. Moskovitz and Dr. Friedman, who oversaw this project and mentored along the way. Thank you for your attention, and I'll answer any questions you have.